My talk is about the bypass. Bypass surgery has been very important and will be very important in neurosurgery, no matter what we think, but will be important because there are problems in neurosurgery that can all be resolved using the bypass. The title is about the past, the present, and future. I'm talking about the past. The first slide, you know, I showed you in July 16, 1969, the human beings got to the moon. Although some people still nowadays don't believe we've even reached the moon, finally we reached the moon because we know it was very important for humanity because we know in part partly what we are because of this landing. We know our origin. The moon was a piece of the Earth, a celestial body the size of Mars, crashed with the Earth at the very beginning of the formation of the solar system, and the moon was formed like a piece of the Earth. We know that from that landing, we knew that the surface of the moon was very similar to the Earth. And now what it is on the rays, the rare elements, there are plenty of them on the surface of the moon. But more important, we put mirrors at that time in the surface of the moon, and with laser now, we know that we learned that the moon is getting away from us, it's escaping for us. It's amazing. But the maths explaining all of these discoveries is very simple compared to the maths. We need to understand the circulation of the blood flow in the human body. Aneurysms were made from the prehistory. We know the growth of the bone after a craniotomy. We need the speed of the growth of the bone after a craniotomy, so we can tell now from these Paleolithical craniums that almost 50% of them survived. Of course, they were not doing bypass or complex process, but almost 50% survived. In October the 30th, 1967, it's not the photo of the Gassi performed the first bypass. And we have to be humble. I wouldn't compare the human beings reaching the moon with the first bypass. But the question is, how long did it take the humanity to reach to the point, to technical and theoretical point, to perform the first bypass? Almost the same it took to get to the moon. It's the only question. Of course, we have to be humble, and it's not the same for humanity reaching the moon with the first bypass. But it took a long time. And how was the history of the vascular, cerebrovascular, and microsurgery, what we need to reach bypass? If we go to the beginning, this is the Everest papyrus. It's the first document in human history talking about vessels, arteries, and veins. And they call they use the word net to describe the vessels. Suruta, an Indian physician, was the first to discuss about the importance of hemostasis, 600 BC. Then Hippocrates was the first to use the word apoplexy. Apoplexy, the result of the occlusion of a vessel inside the brain. It was Hans Chiari in 1905, the first to link, without any evidence at that moment, the occlusion of a vessel with the apoplexy. But Hippocrates, in the 4th and 3rd centuries BC, was talking about apoplexy. Herophilus of Chalcedon was very important because was the first to talk, this is a Latin translation, of course, to talk about the rete mirabile, the wonderful net, the collateral vessels in the base of the brain very important now, the study in the ischemia cases. Of course, they described many anatomical things because it was very important, but this was the first time in history we talk about the red epinephritis. Galen of Pergamon was very important because we further tried to explain the apoplexy, but was the first of the Occidental, you know, Sutra, the Indian physician, was talk about that before, about the importance of hemostasis. Avicenna and Abulcasis in the Middle Ages were very important physicians. They, Avicenna wrote the Canon of Medicine, a very important book in the history of medicine, and Abulcasis was the first of talking about the ligation of the STA, the superficial temporal artery. You saw in the Middle Ages, he described the way of dissecting and occluding the STA in the Middle Ages. Then the revolution in the Occidental world came in the Renaissance with the Humani Corporis Fabrica by Andrea Vesalius. He redescribed almost from scratch all the human vasculature and anatomy. And later, Thomas Willis described the circle of Willis. Gerard von Swieten, a Dutch scientist, was the first who proposed the mechanism of cerebral embolism and stroke. We're still in the middle, in the Renaissance. Then the history went on with the human drama, the human existences, because a lot of these breakthroughs in the treatment of vascular pathologies were made in war. During the 16th, 17th, and 18th century, most of the discoveries about hemostasis, treatment of traumatic aneurysms, and things like that were done in war, were military surgeons. And in the 19th century, Thomas Murphy was the first to perform end-to-end arterial anastomosis. Was a very, very important American surgeon. And then this is the man. This man is Alexis Carrel, which in 1902 described the triangulation technique to perform vascular anastomosis. This was the breakthrough, definitely, in the history of medicine, in the to perform vascular anastomosis. He won, you know, he won the Nobel Prize for this work. Now, in another war, in this Romuald Gegorsky, born in what is today Ukraine, now it's Ukraine is on the race because of the war, but in two wars, in the First World War, and then in the in the war between the Polish and the Bolshevik War, he performed 40 cases of vein grafts to repair arterial defects. First time in history. Again, the war, again, genius, treating to help his fellow countrymen. Then, in 1939, was the German and Tafel performed the first encephalomyosynangiosis, an indirect way of revascularization. Against the war and war and war. Gasmonix, another genius, developed the angiography, and now first time in history from the Egyptians, we could see from the inside what was happening. And now the theory, the theoretical approachment of Hippocrates, and then Hans Chiari in 1905 were proved. The occlusion of a vessel caused the stroke. The Gasmonix won the Nobel Prize not for this, for other things, but. And then this, another genius, an American neurologist, was the one who could foresee the future. Maybe we will be able to perform a bypass and supply blood to the distal vessels to the occlusion. Was Charles Miller Fisher, very important in history of bypass, this neurologist. In 1953, Michael DeBakey performed the first carotid endarterectomy, another breakthrough in history of neurovascular surgery. Then the microscope came. So far, the micro hadn't been used, but this was a Swedish otologist who introduced the microscope in medicine, and then this Theodore Kurz, an American neurosurgeon, introduced the microscope in neurosurgery. And then in the 60s of the last 20th century, in the same decade, the human beings were preparing to go to the moon. There was a schooling, especially in the United States, of improving the microsurgical techniques. And in Vermont, they developed the first laboratory for training and preparing microsurgery. They did a lot of things, along with Julius Jacobson and Suarez in Vermont. They performed the first embolectomy, the first anastomosis, the first a lot of things. And at the same time, in 1963, these guys this is Kunlin, the photo of the guy on the photo is Kunlin, Warringen and Kunlin performing nicely. They were very unlucky, you know, because they are almost unknown to the neurosurgeons. But in 1963, they performed the first easy IC bypass between the common carotid and the ICA using saphenous veins. The case was successful, but the patient died. Successful technically, and the bypass was opened, but the patient died. That's the reason why everybody forgot this thing. But in 1963, a high flow bypass was performed by these two guys. Cassie Jasargil, the giant of modern neurosurgery, received news about the case of Warringen and Candling and wanted to improve. He was frustrated because in the 60s, he received a patient, a female patient with an occlusion of a vessel, and he couldn't treat the case. He was disappointed. He knew about the case of Warringen and Candling and moved to the United States to improve his technique, to microsurgical skills, and went to Vermont, of course. It was like the Lyceum of Athens of that time of microsurgery. And he performed, he trained, he surpassed them in technique, and was able to perform on October 30th, 1967, the first STA-MCA bypass. Then this changed the world of microsurgery, and came the golden 70s with a lot of very important people. Here you have the photo of Robert Spedler, one of my mentors, who are genius of neurosurgery, and this is Lockheed. In the 70s, basically, they developed the original technique of Warringen and Candling. They improved the STA-MCA. At that time, in 1962, Jasargil performed the first STA-MCA in a Moya case ever in history, a disease described by Japanese people some years earlier, but before that, he was the first who performed STA-MCA bypass in Moya. And these guys, Lockheed, Spedler, then Schund, Hausmann, they started to study the flow. They were conscious at that time that we will have to know more about what is happening inside the brain. It's not only a technical thing. And they started, along with the industry, they started to develop means to measure the flow. The Xenon CT, and started to use the Doppler, the recent discoveries to be able to measure the flow. But then in the 80s of the last century came the trials. The trials, you know, there was an international trial of bypass for ischemia cases. And then in the 80s, it started in 1977 and finished in 1985. And the conclusion was bypass there is no point to perform bypass in ischemia because the medical treatment is better. We had but we had a problem at that time. We all know neurosurgeon cases, impossible to treat. They receive the maximal medical treatment and they start suffering strokes. What can we do with these patients? Some people started to, didn't agree at all with the of course, they believed the study, but they went on doing ischemia cases in these selected cases. And these people were doing well. So they repeated the study. At that time, when I joined the neurosurgery, most of us, the people around 50 or 60, started to work in this moment of history of neurosurgery. Failure of the first cooperative study and waiting for the second study. And I attended to the development of this cause study, the carotid occlusion study, because I was in St. Louis going every year for these years, and people were very excited with this study. But in the end, the result was, again, favored the medical treatment. Why? Because unexpectedly, the medical treated patients behave far better than forecasted before. So we still have the same problem, but we still have these patients, these ischemia cases, failing the maximal medical treatment and still suffering ischemia. So we still have to do this. Now, of course, in Japan is synonym in vascular surgery of perfection, of at least pursuing perfection. They performed the JAM trial. We were waiting, and of course, for them, the result was positive, favored the surgery. But why? They were studying hemorrhagic cases in Moya Moya, only a few subgroup of patients. So the question is not solved, but we still have, all of us have people under medical treatment not improving. So we have to perform a bypass in ischemia. Then in 1993, other surgeons tried to develop safer procedures. This is Professor Tuliken, other of my mentors. We are in his lab in Utrecht. He developed a non-occlusive way of opening the wall of the vessels. So with a laser, we put a laser on the wall of the artery, and the laser took out a piece of the artery. So we didn't need occlusion at all because we performed the anastomosis before taking out the flap. But the problem was the size of the openings and didn't allow us to work with the small vessels. The minimum was 2.6 and it was too much. 2.6 millimeters was too much. And we couldn't control the flow we put inside. So besides, it was very expensive and we quit this. Then this is Fabi Charbel, another of the giants of recent vascular neurosurgery, developed the flow meter. Now they are developing even more convenient because it's somehow inconvenient, this model, but a device to measure the flow, because the Doppler is only a sound. It's okay. We know the aneurysm surgery develop our ear, like when we attend classical music, and we know if the flow is good or bad, but we don't have a figure, and we need a figure. I don't know, 13, 60 point something, because we know much more about the flow inside the brain. Now we need a figure. Otherwise, you can do bypass. And this guy, Fabi Charbel, developed the flow measurement, very important. We're using it. When I started neurosurgery, I did my military service in Spain as a frogman for the Navy. This was the last photo I took from Cartagena, from the window of the house before joining neurosurgery. I still practice from time to time spear fishing, and what struck me when I started in neurosurgery. It was very similar to perfusion because we have to take, you take a deep breath and you do everything without breathing again through a small glasses. The same. It reminded me quite a bit to the situation we have in the microscope. Economy of movements, and what you see is through sunglasses. In this case, I trained in La Paz Hospital in Madrid, where fortunately we had a lab to train. It's very important if you perform bypass to go to the lab and train everything in animals, perform your skills before you go to the OR. It's very difficult to practice things in human beings. Unless you suffer, the problem, Warringer and Canlin suffered. The patient is going to die, and it's worth it. If the patient doesn't go well, it's worth it what we do. We can go wrong if the patient don't go well. Then thanks to this man, Salim Abdul Rauf, I could go to the States and improve with the best in the world at that time in bypass. Then, what does consist the cerebral surgery? What is the revascularization surgery? It's put blood from outside the brain inside the brain. It's okay. The blood inside the brain comes from in the supratentorial compartment comes from the ICA. In the infratentorial compartment comes from the vertebrals and the basilar. Okay. Most of the time we're using branches of the external carotid because it's in handy. It's very, but we can use more distal bypasses. But most of the time it's the same. And what we trying to achieve is a good result. And this is the example of what is not, what we don't look for, apart anastomosis. If we are not very accurate, the intimal response, what Alexis Carril realized from the beginning is that the intima is the most important part of the vessel when we perform anastomosis, because we have to achieve a perfect intima to intima apposition to avoid this kind of scarring in the wall of the vessel and thrombo. This was the problem from the beginning, so we have to be very accurate. You need a very, very focused training to achieve the basic technique to do this. Again, this is the man, Alexis Carrel, Nobel Prize for surgical research. Unique, almost unique in the history of medicine. And you see, he stated 5 rules. And if you see the point 5, approximate the intima code in order to produce as small scar as possible. This is still, when something is good, it stays there for, I wouldn't say forever, but for a long time. And you see, define rules of Alexis Carrel: avoid twisting and stenosis, continuous washing, use very fine and sharp and round needles, and approximate internal codes. It's very actual. When should we consider bypass surgery? We've been using bypass surgery for tumors. Now we seldom use bypassing tumors for several reasons, because we're using less invasive approaches, like you saw today. We used to, when I started neurosurgery in the late 80s and first 90s, most of us were using huge approaches, and from time to time we sacrificed vessels. And then radiosurgery appeared, and many cases are treated with radiosurgery. So in skull-based surgery, the best revascularization, like Osama Al-Mefti always say, is the best revascularization is preservation. But sometimes we have to repair vessels. We will see in cranial-based tumors, but we don't prepare cases for bypass. But we still use in some cases of ischemia, is the second field of bypass, and especially we are using in aneurysm surgery. Nowadays, if you want to become a cerebrovascular surgeon, it's impossible. You devote to clip aneurysms or to treat with aneurysms if you don't master the bypass. You need to master at least some kind of bypasses. What can the bypass offer to the patient? Only two things: flow augmentation, flow replacement. Flow augmentation, if there is not enough flow to a region of the brain, we provide through the bypass flow enough to this region of the brain. This is flow augmentation. Flow replacement, we cut the flow to a region of the brain because we have to put the, I don't know, ICA, MCA, whatever, and we put blood in this region of the brain through the bypass. This is flow replacement, or both. Sometimes we need both things. What types of bypasses do we have? We talk about 3 generations. Now, Michael Lawton is talking about 4 generations, but it's only a technical issue. I stick to the 3 generations. Very easy. The first generation, the original STA-MCA. We get a final branch of the external carotid artery, especially the STA, but could be the PPA, the posterior, the PAA, the posterior auricular, or the occipital artery, or even the middle meningeal artery, distal branches or occipital artery, distal branches of this, and put directly to a branch inside the brain. What Jasper did, this is the first generation, and this provides flow augmentation. The second generation is what Warringer and Kuringer started, and then Spetzler, Hausmann, Schön developed in the 60s. Is put a graft with using vein grafts or saphenous vein graft most of the times, or in my career I used mainly radial artery because several reasons, not the point in this talk. And this provides high flow bypass because the flow was very high. It was physical. We will see now why. And the third generation bypass is the intra-intra. The preacher of this third generation bypass was Michael Lawton. We are on the spot, we have a problem, and we solve with vessel inside the brain. It's very important because the first 2 generations provided us with possibility of flow augmentation and flow replacement. Of course, we take for granted that the 2 first types provide also flow replacement. But the third generation is a local solution. So it only provides flow replacement, but not flow augmentation. The flow is what it is. We cut, I don't know, a superior cerebral artery or a PCA in a surgery, and we put it together again. It's the same flow. It's only flow replacement. Okay, important to take into account. This is the possible law. I told you that taking us to the moon, the maths of that is Newton was a genius, but when it's the typical thing that is very complex to imagine, but then to explain is very easy, the Newton laws. To try to explain mathematically what is happening inside the vessel is nowadays impossible. Maybe with quantum computers now, because we need modeling, will be feasible in the near future. But so far, it's been impossible. The most close approximation to what is happening is very old. Is the Hagen possible law. You know, Hagen was performed some experiments in the 30s of the 19th century, trying to explain the Estacional laminary flow. What is this? It's a fluid that is incompressible and uniformly viscous. They call that Newtonian fluid. Going through a cylindrical tube of constant circular section. This is not exactly what is happening. Our arteries and our veins are, because of the pulsation, are dilating. This mathematically is a nightmare. It's impossible to change. But the closest approximation we have is the possible law. What happens in possible law? Look at this. This law, what tells you is the flow we have through a section of a vessel, of a tube, not a vessel, because the vessel, because of the pulsation, dilate. If they are fixed and the viscosity is uniform, we have the radius on the numerator elevated to the 4. So the radius is our friend. The larger the radius, the higher the flow. And we have in the denominator the length of the vessel, and this new letter, which means the viscosity. So we have a friend, the radius, and we have two enemies, the length and the viscosity of the bypass. So it's very important, very important to have the patient hyperhydrated and with high tension during the bypass. You can be the best in the world, you can be a Spätzler or Rokuya Tanikawa, and the bypass will occlude if the pressure is low, I can tell you. So, according to the possible law, the bypass it needs to have a good inlet, to be as short as possible, and to have a good outlet. These are the most important things. And this comes directly from the possible law. Does anything influence the blood flow besides enlarge the radius? Because so far, the only thing we could do, we as surgeons, because the anesthesiologist can put higher the pressure, lower the viscosity, and it's okay. But the only thing we could do is to perform a short bypass, as short as possible, and enlarge the radius. The only thing we could do. And in the last years, we started to know more things about the bypass, not only the radius, because it's important to the vessels receiving the bypass. And we started to study the flow in the receiving vessels. And important is the current capacity of the STA, of the donor vessels. But it's very important, this concept, the integrity of the MCA network. It's not the same. Depending on the case, our brain is more prone to receive blood than in other cases. And when the vessel doesn't want to receive blood, it's very dangerous sometimes. And they come the hyperperfusion syndromes. And this is because of the integrity of the MCA network. The current capacity of the MCA, there are a lot of things, I will skip this, but it's very important. Depending on the type of bypass we perform, how we prefer, the diameter, a lot of things. But this is what I tell you, the MCA network. Besides the parameters of the possible law, we have the quality of the MCA. I'm talking about MCA because most of the time we bypass to the MCA, but this applies to any vessel in the brain. The quality of the MCA network determines what happens with the bypass. You see, this is a good situation. When we see this is a good collateral network. We perform STA-MCA and we get blood down to the M2. This is a good collateral network. If you see this after a bypass, this is right after the bypass, we perform, we know no problem is going to happen. But sometimes we get this. We only get flow in the angiography after the bypass, very close and very diffuminate around the bypass. Ooh, very dangerous situation because it carries risk of bleeding or infarction on edema. Absolutely independent of the possible law, because it's the quality of the recipient vessel. Treatment indications nowadays in bypass, in ischemia for bypass, progressive ischemic symptoms and evidence of inadequate CBF or CBR and no contraindication to surgery. Now we can measure with MRI or with CT functional, we can know the transient, the mean time and the flow, and we decide based on that and the clinical. Of course, cases not responding to the medical treatment, the international treasure that. But our first goal, at least in my experience, is the bypass. Is the aneurysm surgery, excuse me. The complex aneurysms from time to time require bypass. In my service, we are quite surgical. Of course, we embolize a lot, but we operate a lot, and we need bypass in some cases. It's very difficult to define what a complex aneurysm is because it would depend on the surgeon. It would depend on the situation of the surgeon. It would depend on the many factors of the patient. But for me, the objective definition of a complex surgery is an aneurysm that is difficult to treat without risk to the patient. No matter who is operating it, and if we have here an aneurysm in your team, and you are trained in treating aneurysms, if the lowest risk is not complex. If the risk is high, it's high complex, but it's complex. So, but times we have to follow to treat the aneurysms the principles of vascular microsurgery. What are the principles? Clean and atraumatic dissection, proximal vascular control, and respecting the perforators. This is the, if you can do this, if you can achieve this, you can safely operate on a patient. The first thing for the young people, our young colleagues, you have to do is follow Gassi-Jasarhill, and the first thing before be trained in cranial base and things like that, learn how to navigate the cisterns. It's very, the first rule in vascular surgery, clean and a traumatic dissection. We're here opening a Sylvian fissure, treating a MCA and an ACOM aneurysm. And the first thing you have to know is to cleanly open the chiasmatic cistern, cleanly open the cisterns to deal with. In this case, for example, open even the interhemispheric fissure, very important in ACOM aneurysms. You have to learn, you have to master this. Atraumatic, you have to get to the aneurysm atraumatically. The first goal of the three is achieved. So if you can't do this first step, don't go ahead in vascular microsurgery. Then the second thing, the proximal control, like you see here, we control A1, and now we put a clip in the aneurysm. The next question: what defines a cerebrovascular surgeon? We are all men are equal, no? The illustration statement, but we have differences among us, and the differences are our anatomical knowledge, our microsurgical skills, and experience. Experience alone is very important. Experience alone saves a lot of things to the patients. It's very good. Anatomical knowledge, vascular skills, and experience. And forget about the rest. Of course, we have to be humble, and we have to be sensible with the patients. But I think most of these things, even your parents can teach you that in your education at home. But the anatomical knowledge, the microsurgical skills and experience should be yourself, you alone. Why an aneurysm is complex? Because of the size, the quality of the wall, and the localization. Of course, the size is the most important factor to become an aneurysm complex. And this is the reason why we're doing bypasses most of the time, because of giant aneurysm. The management of complex aneurysms, of course, needs skills in vascular microsurgery and screw-based skills. Now I'm starting to talk about cranial-based surgery. It's impossible, I told you before, to become a cerebrovascular surgeon nowadays if you don't master bypass. But it's equally impossible to become a cerebrovascular surgeon nowadays if you don't master at least part of the cranial-based surgery. Of course, endoscopic is another issue, but you should master a lot of things. The proper drilling of the lesser wing of the sphenoid, perform a proper CTA approach, retrosigmoid, perform middle fossa approaches, the Kawasa approach, of course, the far lateral approach to the pike aneurysms. Without the skull base, is no vascular surgery today. And then a third thing, commitment, physical and mental work. Why? Especially for the young people. Because most of these things happen at night, because aneurysm, unfortunately, they rupture. And we have to be prepared to go there. There are very good surgeons that can afford to do this, because they have a lot of operations. To be a cerebrovascular surgeon is like to be a monk. You have to be ready for the patient. It's that clear. Aneurysms comes when it hurts, at night, on weekends, things like that. Microsurgical techniques for complex aneurysms. Of course, reconstruction with clips, very important. To be able to reconstruct an aneurysm very fast, lowering the transient occlusion time. Careful handle of the temporary clipping, of course. Clipping strategies with fenestrating clips and then the bypass. We reach the bypass. Sometimes it's impossible. Even if we master the clipping of the aneurysms, it's impossible without bypass. One example, in many centers, most of these aneurysms are referred to embolization and put a flow diverter. This is the question is this a complex aneurysm? Very small, paraclinoid, but true ophthalmic aneurysm, dorsally pointing aneurysm. This is not a complex aneurysm at all in this case. And this is what we do. We need to master the cranial base approach. We've taken out through a mini-interior approach, a very minimal invasive approach. We took out the anterior clinoid extradurally, and now we're opening the distal dural ring. This is what you have to master of cranial base to perform a surgery on this aneurysm. You see, we're opening the distal dural ring, and once we achieve that, of course, we have in all the paraclinoid aneurysm, I perform proximal control, one of the rules in the neck, always. No matter if I can control the ICA in the clinoid space, in what we call C3, no matter. I always control that from the neck. And when you have opened the distal dural ring, it takes time. Now we are assessing the ophthalmic artery very accurately. We can preserve the ophthalmic artery. We open the distal dural ring, and you put the clip. You don't need bypass for that in this case, because it's very simple. The quality of the wall is quite good without calcium, and the size is not that big. Very straight clip from posterior to anterior. At an last, you look at the craniotomy, very, very small. It's not a complex case. Reconstruction with clip. Unfortunately, in our fight against the aneurysms, we don't usually have this clean situation. With a clip in the neck, what you imagine when you're a resident, you solve the situation. In large aneurysms, the goal is to minimize the temporary clipping, but reconstructing with clips. What we'll first do is to put a pilot clip that allows us to take out the temporary clipping and then go on with the reconstruction. And in these cases, sometimes we perform prophylactic bypass. If we foresee a long occlusion time. What is a long occlusion time? If the blood pressure is higher, really high, 20% more than the regular pressure for this patient, it's very difficult to see a patient developing changes in the neurophysiologic monitoring, the motor or the sensory potentials, going up to 15-20 minutes. We very seldom see that. You raise the blood pressure and nothing happens. Of course, we don't go to push the patient to that moment. And if we foresee a 20-minute occlusion in a giant aneurysm, we perform that, performing 3 small 6 minutes occlusion and opening, because it's absolutely different. It's much safer. But we don't go, I don't want to go beyond 10 minutes. If I'm going beyond 10 minutes, and with my experience, I can foresee when I'm going to need more than 10 minutes, I put a first generation STMCR, whatever, bypass prophylactic, and the situation changes. Now we have a case, this giant ICA aneurysm with occlusion test not tolerated. On test not tolerated, but with collateral circulation, coming from the ACOM from the other hemisphere, and coming from the PCOM from the posterior circulation. So it's a quite good situation. But we have asymmetry in the venous times, in the BTO, in the balloon occlusion test, and the patient didn't pass clinically the PTO. So in spite of the fact that we have collateral circulation, we can't occlude this ICA because it's a matter of time, these patients suffer a stroke. So in this case, we have to put a prophylactic bypass because I don't know for sure when there is calcium in the wall and with this size of aneurysm or ICA aneurysms, we don't know for sure that if something is going to happen to the patient. And unfortunately, I learned this failing with patients. With my colleague here, we suffer a very, you don't forget these cases, you know, because you feel that you have the situation solved, all the neurophysiologic monitoring is okay, everything is okay, but in the end fails. And it's as easy, and with this size and with calcium in the wall, put STMCA, and everything changes afterwards. Now, in this case, I didn't know before if I would be able, this is the situation I told you, we have collateral circulation from the right, this is a left aneurysm, from the right side, from the ACOM, and from the vertebral, from the posterior circulation. And in this case, what we did was the same. We prepared the neck for the suction decompression, because in these giant ACA aneurysms, we have to aspirate and debug the aneurysm before doing the clipping. Prepare the superficial temporal artery, you know, to do the aspiration. We prefer that to go from the carotid because of we suffer in several cases in dissections, especially when you come from the internal carotid. And we perform the bypass. Now we have controlled the neck, prepare the STA to the superficial temporal, the superior thyroid artery to perform the aspiration, and was the STA-MCA in place. So we are ready to go and look for the aneurysm. We perform the stradural approach. We take out the anterior clinoid, open the distal dural ring, as I showed you in the video, and then start to widely open the cisterns to reach the aneurysm. We reach the aneurysm, and we try to dissect to get the proximal neck of the aneurysm. We try to dissect it from the ophthalmic artery, but because of the size, of the quality of the wall, because of the calcium, we have to perform the suction decompression from the neck. That's what we are doing here. And we perform the suction decompression. I see and I reconstruct the aneurysm. But I realize that the only thing I can do is to occlude the proximal neck, because it's impossible to take out all the aneurysm without leaving a Redman. It's not the point in this case. And the bypass was enough and to supply the blood after occluding this. And I will show you this is the suction decompression. And this is the situation after the bypass. You see a lot of flow coming from the other side. You see, we have occluded the carotid, but it wasn't enough. And you see the bypass here. You only need this, but without this, these patients will suffer a stroke, left side, aphasia, hemiplegia, disaster. So a simple bypass in a complex aneurysm, but impossible to do without the bypass. In other circulation, for example, in ACOM aneurysms, where we have giant aneurysms, we have to go to the third generation bypass. It's very difficult to put. Sometimes we did it, but it's very, you need to violate one of the rules, one of the lessons of the post. We have to be sometimes put the two branches of the fissure to reach the distal anterior communicating artery, anterior cerebral artery, the pericallosal artery. So in these cases, we perform a lateral bypass, a third generation, only flow replacement. Like in this case, actually, I've operated on several of these giant aneurysms, And sometimes it's amazing, but there is collateral flow, and you can trap the aneurysm. In this case was sent for friends from Cordoba, the south of Spain, to Madrid. We operated in there, and we could reconstruct only with a simple clip. Of course, we use the interhemispheric approach, anterior interhemispheric, to loosen aneurysms. But in this case, it was impossible. It's a larger case. In this case, almost always they are A2, actually A2 aneurysms, never A1. I don't know why, but this giant anterior communicating region aneurysm, giant aneurysms are always a bit A2, so you can trap the aneurysm without risk to the perforator, distal to the icon, what I mean. But in this case, you have to trap this, and there is no collateral flow. With this is a lateral anastomosis through interhemispheric fissure. What happens in these cases is that the size, the bulk of the aneurysm is lifting the vessel for you. So it's not that deep. It's easier. Its nature helps you in these cases. In this case, we perform a lateral, and you see I will put you the ECG. You see, we've trapped the right A2, and now the flow is coming from the left A2, and you see we have coming from the left A2, we have flow in both A2s. This is a lateral third generation bypass. We've used this is a giant MCA aneurysm. In this cases, this case was complex because I will almost skip this case, but we have trifurcation. The STA only have 2 branches. We could do several things here. Combine a radial graft for one of the 3 branches and use both what we call a double barrel STA bypass to the other 2 branches. But in this case, look at this. These arteries here are almost kissing. And what we performed here was a bypass to one branch, a bypass to other branch, and then a lateral to the 3rd branch with one of the 2 branches. And in this case was enough. I will skip the ECGs. And then we go to the perforators in anterior circulation aneurysms. This is an M1 aneurysm, one of my favorite topics. The M1, this is a rupture case, came to Toledo, to our place, and it's a very nasty aneurysm, partially calcified, you see. And the problem here is we try to occlude this. We have to provide a bypass distal for the MCA territory, okay. But the problem here are the perforator themselves, the lenticulostriate arteries along the aneurysm. We know anatomically that the lenticulostriates come from the inferior and medial sides. And most of the bulk of this aneurysm is dorsal. So maybe what we can do here, of course, we need a bypass. We see both branches of the STA are feasible, around 2 millimeters, more than enough to perform the anastomosis, and prepare the plan. First, we perform a first anastomosis, STA anterior branch to the upper trunk of M2. We're putting the temporary clips here, open the vessel, you see. We're working in the Sylvian fissure. Very important, the technical issues here. We need aspiration because we don't want a messy. If there is blood in the field, you have problems. You open the artery, then we perform the second anastomosis. The STA, posterior branch, the parietal branch, to the inferior trunk of M2 trunk. So perform a double barrel. You see, we point the bypass, the toe, what we call the toe of the bypass proximally, and we do a running suture. You see, I perform the posterior one from the inside because I'm trying to get a bypass as short as possible. You see, with the now we run the suture. We already performed the other work from the inside. This is what Michael Lawton calls the 4th generation bypass. but for me, it's a first generation bypass. We perform the anastomosis, of course, and then once we have two bypasses in place, we can go proximally to achieve the proximal control. What happens in these huge aneurysms is that we can't get the proximal M1. It's almost impossible. And we start to get proximal control to go into the ICA and to the A1. And we first the first proximal control. But if something happens in this step, and believe me, it do happens from time to time of bleeding of this giant aneurysm, you can control it. We put the first clip in the ICA. We put another one on the now you will see on the A1, and then we don't have problem in the distal circulation because we have blood coming from the MCA and from the bypasses, but we have to start reconstructing the aneurysm, and we put a distal clip to trap the aneurysm. At this moment, the lenticular striates are at risk because they don't receive flow distally. Now we check that with the Doppler that the aneurysm is not receiving flow distally, and now we aspirate the aneurysm. In giant aneurysms, you need several aspirations because for several reasons, for small perforators or even for the vasa vasorum, the aneurysms refill again several times. Now we are starting to work in the dorsal side of the wall of the aneurysm. You know, refilled. It's always the same with giant aneurysms. Again, we trying to shrink the aneurysm through aspiration, and I am starting to see. I reveal the dorsal wall of the aneurysm with bipolar, and I start to see the lenticular striates to control them. You see, because they are inferior medial and at this place here. This is the second, and then with the aneurysm tract, you know, we are remodeling the dorsal wall. Why don't we occlude proximally and leave the things like they are? Because otherwise it's more difficult for the lenticular striates not to have problems. Let me see if this is, no, I have to go to the next one. This is the situation after reconstruction. What with this is to reconstruct the aneurysm, and let me see if I have, no, it's the same. Okay, this is the situation. We have occlusion, proximal occlusion in the end because we couldn't spare it's a sick vessel. We don't want to leave this vessel open. But we just don't put the proximal vessel and leave it alone. We also reconstruct the wall of the aneurysm, and you will see why. Because this is the situation. If you leave the distal aneurysm open, the refilling from the bypass will create a problem. They sometimes even grow and rupture afterwards. You see here we have flow to all the perforators, and you still see distally the M1 reconstructed, but with proximal occlusion. Otherwise, with the combination of these two techniques, wouldn't be treated. This is the situation, you see. And now, from posterior, I will go from posterior fossa aneurysms like this one. This is a P2A, P2P aneurysm. We prepare for the bypass. Unfortunately, sometimes we don't need the bypass. This is the situation. A subtemporal approach. It's not exactly a cranial based approach, but you need to master the cranial based approach we take out a bit of para-hippocampal gyri in these aneurysms, like you took a bit of gyrus rectus in the, we suffer intraop rupture, you see, very easy to control because we achieve the proximal control before, and the technique is the same. We shrink the aneurysm, we trapped the aneurysm, and in this case, we were able to reconstruct the aneurysm. The technique is the same. We didn't need bypass in this time. We reconstruct the case. Unfortunately, you will see the control now. We were able to reconstruct this. Of course, very important to have neurophysiological monitoring this time, because it's impossible to know what is happening. Otherwise, you know, the PCA has a lot of perforators to the. This is a year later. You see, totally reconstructed the artery. But there are cases like this one, 8 embolizations. These are very funny. We have to be open to techniques. This patient was embolized 8 times. It's amazing because this was a female patient and was my mother knew this girl because they attended church in Galicia, we're from the north of Spain, together. And she was embolized 8 times in a very close hospital. And I didn't know anything about this patient. I didn't even know my mother knew this patient, but they referred the case to me without knowing anything. I don't know, 6 years later, after the 8th embolization, with a severe compression of the, you will see here, of the brainstem, and suffering, starting to suffer hemiparesia and extrapyramidal for mesencephalic compression because of the coiling. And in this case, what we did was this was the situation. Look at this compression because of the cleats, because of the thrombus. Of course, embolization is very good and is superior to microsurgery many times, but not in this case. What we did, again, proximal control. This is the PCOM, P1, P2. After achieving proximal control, we go to the aneurysm. With CUSA, we aspirate the aneurysm, and then a terminal suture, and the problem is solved. So sometimes we have to, this is one of the reasons why I tell you, no matter how the embolization is improving, we have to keep on working on bypass. This is another case, SCA aneurysm with a distal STA superficial cerebellar artery, and solved. If you see the literature nowadays, you see in the late years, the number of reports published on on bypass operations significantly decreased after the approval of flow diverters for aneurysm treatment. This is a reality. This is the situation. The flow diverters are the solution for many cases. It's still very expensive, but very good. I have nothing to say about that. But whenever there is a need of flow replacement or flow augmentation, the bypass will continue to have a role in neurosurgery. This is my conclusion. Thank you very much.
Why did you not use the vein bypass? What is your conviction?
Yeah, I use the R3 more. Now things are starting to change because I'm using more vein in the last years. I will explain you why. But the main reason is why I started doing bypasses. I read all the literature of the cardiac surgeons, and I see the patency, the long-term patency with vein grafts and with internal mammary artery. What's the other point? The problem with on the other hand, most of my heroes, Robert Spetzler especially, were using vein grafts. But when I went to the barrel, he moved to the radial artery and changed my mind. Because the problem with the radial artery was the vasoconstriction sometimes. But using calcium channel blockers, the problem was solved. and with the pressure dilation technique published by Laminary, but discovered by Kamiyama in Japan. You basically you destroy the the muscle of the, and with pathological studies, with a very good paper, they proved that there was no problem with the intima, the most important, the only important thing, the most important thing of the artery, and we started using artery. What was the problem with the artery? And maybe the reason of your question, the size is not always adequate, especially in small women. We have problems. Sometimes only because of the length, impossible to take out. You need to get 18 centimeters, more or less. And it's almost impossible sometimes with the radial artery. And now the radial artery, because of the endovascular, because we're going from the radial artery, is starting to be sacred. Please don't use the radial artery. But what happened in the last years? That the vascular surgery improved a lot how to extract the vein endoscopically, changed our life forever, because one of the reasons why we didn't use the vein was the scar they have, and probably sometimes infection in the leg, especially when you went to the groin. And the second reason, we were reluctant to take out the valves. You know, when you use vein, you know, you have to put the vein in the same way, because the valves, the veins are designed to take out flow from distal to proximal. But what was the problem when I was young? The distal was smaller than the proximal, what you put in the MCA, which is quite big sometimes. But in the last years, taking out the veins with endoscopical extraction, we're using more veins. But I would say 90% of the cases, 90% of 12 cases a year, we operate on a lot of aneurysms a year, but we perform 12, 15 a year. It's not that frequent. 90% of the cases, I would say, if we perform 15 bypasses, 10 at least would be STA MCA, because with the knowledge we've gained of of the brain circulation, of the figures of what the MCA needs, the ACA needs, the ICA needs, how to handle the perforators, in 10 out of 15 cases with STA is enough. So the vein is regaining a role in this surgery, but STA is taken out, and it's the same anywhere. Because if you see Michael Lawton with his huge series, he moved to the 3rd generation bypass, and when we need, he uses a very short graft, maybe vein, maybe artery, whatever. But again, definitely the vein is again regaining a role.
On the giant paraclinic, do you have any experience on the contralateral going for clipping when, because we know for full diagnosis, but we know they are too risky in time. But do you have any experience on contralateral?
In giant, I have a problem to go contralateral. I have I would say, quite a nice experience in contralateral paraclinic, because especially, but I would say in small. In small, it's definitely quite easy. To the young people, if you go from the other side, you have the optic nerve. If you dissect above the optic nerve, you go to the Japanese call the C1. You go to the bifurcation of the ICA. If you go below the nerve, you go directly to the ophthalmic segment of the SCA. And if you see the anatomy of the anterior clinoid, the distal dural ring comes from medial to lateral, from proximal to distal. So, to sum it up, you have much more room to operate coming from the other side. You seldom need, for a small aneurysm, the control to take out the anterior clinoid. What is the problem? When I use, I've been using, because I don't know why, but the incidence of multiple aneurysms in the last years, here in Albania, is the same. we're watching more and more patients with multiple aneurysms. And I have a small paraclinoid aneurysm and I don't know, an MCA from the other side of carotid ICA bifurcation aneurysm. I come from the contralateral with no doubt. What is the only problem? The cervical control is much more difficult. It's feasible, but it's much more difficult because you have the patient placed like that. And the big problem, because your question was from the giant, I can check all the circumference of the wall of the aneurysm. And if you, unfortunately, you have calcium in the other side, you can tear the neck of the aneurysm without control. That's the only reason why in giant, I usually go from the same side. I go contralateral to small aneurysms, but not for giant. Because of the reason, the quality, because of course, if you try something with experience like you can succeed, but sometimes it's very unfair neurosurgery, and there is a calcium, a bit of calcium in the other side, you have a very terrible situation.
Thank you.